Hello everyone, my topic today is Sugammadex, New Road Back Home. So this is a new reversal agent that has been introduced recently, and relaxation is quite a part of our life. Every day we relax the patient, we relax the surgeon, and in terms of muscle relaxation, we have it every day in our processes. So coming to neuromuscular physiology at first, it's not again for me as well. We are not going into details of this, but because we are going to use the terms in this presentations, so I'll just briefly go through it. There is a nerve terminal, axon terminal, which releases acetylcholine in the neuromuscular junction, which acts on the motor end plate of the acetylcholine receptors and causes the channels to open and causes muscle action potential generation and muscle contraction. Now, depolarizing muscle relaxant act by enhancing this effect, whereas non-depolarizing muscle relaxant act by antagonizing this effect by blocking the channels. Acetylcholine esterase, which is a naturally occurring enzyme that breaks down the acetylcholine, which terminates its action. Reversal agents like neostigmine, which are acetylcholinesterase inhibitors, enhance the cholinergic effect, and they also act on the muscarinic receptors. So what are the currently used neuromuscular blocking agent and the reversal agents? There is a depolarizing neuromuscular blocking agent like succinyl choline, which is broken down by pseudocholinesterase, which is naturally occurring in the blood. Non-depolarizing muscle relaxants are basically three classes: benzyl isoquinolones, aminosteroids, and chlorofemerate diesterases. Benzyl isoquinolones like atracurium, cisatracurium, ivacurium, they can be reversed by neostigmine. They also go Hoffman's degradation, which is enzymatic degradation, so sometimes they may not need a reversal. Aminosteroid compounds have to be reversed. Currently being used are vecuronium, rocuronium, and pancuronium. The reversal agent we use is neostigmine, and Sugammadex is recently introduced. Chlorfumarate is gantacurium, and some molecules are yet to be named. The reversal can be done by hydrophonium. There is a compound calabadion which is being studied in animals as yet, and it would be new reversal agent coming in, which can even reverse the action of succinylcholine. So neuromuscular stimulation and monitoring. So some of us have certainly used it, and why do we need to know about is that the analysis of neuromuscular blocking agents and the reversal agents has been studied on the basis of neuromuscular monitoring. It is a qualitative assessment of neuromuscular block and the recovery, and few parameters that are usually used are train of 4 count, train of 4 ratio, and PTC. So now what you basically do is you stimulate a nerve by placing the electrodes, and you see the twitches response like we see while giving peripheral blocks. So generally ulnar nerve stimulation, you can see adductor pollicis response, and when you give 4 twitches over the 2 seconds. So when you count train of 4, basically 4 twitches, if you seeing only one response out of train of 4, then more than 90% receptors are blocked. They are still under the effect of muscle relaxant. When you see more than 2, then if you seeing 2 twitches, then it is 85 to 90% of the receptors are blocked. When you're seeing train of 4 count of 4, then 70 to 75% of the receptors are blocked. So now when you're seeing all the 4, but you're still saying that 70 to 75% receptors are blocked, what you need to assess is train of 4 ratio. So first response to go is a fourth response, and first response to come as a first twitch. So when you count train of 4 ratio, it is determined by dividing the amplitude of the fourth twitch to the amplitude of the first twitch. Train of 4 ratio less than 0.9 indicates the residual neuromuscular blockage or paralysis and necessitates the use of reversal agent. Post-tetanic count is 5 seconds tetanic stimulus followed by single twitches of 1 Hertz, and you count how many twitches are seen. So if you are seeing post-tetanic count of 9, that tells us about the recovery is about to happen and you are about to see first response of train of 4. And this is general calculation of Beck and Atra. So even having this neuromuscular monitoring, you should not forget to do the routine clinical assessment of the recovery, which should include the skeletal muscle tone, respiratory measurements like tidal volume and respiratory rate, along with neuromuscular monitoring. So this is just to state the fact and once again establish the importance of evidence-based medicine. This is a very old study conducted in 2005 and the statistics are disheartening, but I'm hoping that they have changed in our favor. This was a study performed by giving a questionnaire to 251 anesthesia nurses and physicians. 91% of those had an access to neuromuscular monitoring. 91% underestimated the incidence of post-operative residual chirurgization or residual paralysis. 27 believe that it is possible to exclude the paralysis with clinical tests only, which is highly incorrect, and 45% did not know the train of 4 ratio has to be more than 0.9 for adequate recovery. So coming to reversal agent that we're going to talk about, what should be an ideal reversal agent? It should be efficient at any time. It should give a complete reversal. It should have longer half-life than the muscle relaxant. Should be reversed using any neuromuscular blocking drug. Having said that, Sugammadex particularly acts on aminosteroids and like atracurium, vecuronium, it hasn't shown any great effect. No adverse cardiovascular effect it should have, no adverse muscarinic effects like bradycardia, bronchospasm, abdominal pain and nausea, vomiting. It should not release histamine, should not cause anaphylaxis. It should not depend on the organ for elimination, should not have a ceiling effect. It should have fast onset, it should not produce depolarizing block given in excess, and it should have low cost and it should be available as solution. None of the drugs will fulfill all the criteria, but we should go as close to these ideal residual agent criteria. So why do we need faster and complete reversal? Now many studies have been used to evaluate the residual paralysis, also called residual chirurgization, which is a major concern. In an incomplete or inadequate recovery from the muscle relaxation can be catastrophic and it can produce the complications like airway obstruction, respiratory depression, hypoxemia, rarely even aspiration if the muscles of deglutition are yet paralyzed. So there are two important studies that were conducted. RECITE study, which is residual chirurgization and its incidence at tracheal extubation. And they found that the incidence of residual chirurgization at the tracheal extubation was 63% and even 57% at the post-anesthesia care unit arrival. Now another study which was conducted in US, next of this is RECITE US study. They also found that 64% patient had residual paralysis even when qualitative analysis of peripheral nerve stimulation clinical assessment was done and train of 4 ratio was found to be 0.9. Now what we were talking about was qualitative way of analyzing, that we are visualizing the twitches and judging the recovery, and nowadays they have machines which can actually give us a quantitative results, like it will show train of 4 ratio of 0.9, 0.8 or 1. So they in the study of RECITE US, they have said that the quantitative method is better way than the qualitative method of judging the recovery. Male gender, high BMI and community hospitals were independently associated factors. Now introducing Sugammadex. It's a newer drug to tackle the old complications of inadequate and incomplete reversal. It's a novel reversal agent, reverses the rocuronium and vecuronium induced neuromuscular block. It is a cyclodextrine compound with hydrophobic cavity. It forms a very tight water soluble host guest complex as 1:1 ratio, 1 Sugammadex to 1 rocuronium molecule. It has a major affinity with rocuronium then vecuronium, and little less affinity for pancuronium. It forms no metabolite and it is excreted unchanged through urine. Now, diagrammatic representation, how the rocuronium molecule sits in the cavity of Sugammadex and forms a complex. It has a hydrophobic cavity and hydrophilic exterior. It has a very tight complex with rocuronium, which has a high association rate and very low dissociation rate. So practically every 25 million complexes formed, only one will dissociate. Now, it also causes a gradient shift of rocuronium from neuromuscular junction to plasma, because more and more rocuronium molecules get attached to Sugammadex. It comes in IV formulation of 200 milligrams and 500 milligrams vial, like 100 milligram per ml. It does not need refrigeration. Also, very important characteristic of Sugammadex is it is reversal of Sugammadex is unaffected by blood pH and temperature. So when you have lengthy cases or you have acidotic patient, reversal will still occur when you use Sugammadex. What are the indications? Like bariatric surgeries, morbidly obese patients, residual paralysis after neostigmine reversal, myasthenia gravis and muscular dystrophies. Recent studies shown that Sugammadex has a great results in patients with myasthenia gravis, and it allows us to use a neuromuscular blocking agent in those patients. Patients with wasted muscle mass. This is the reason why Sugammadex use has increased in the ICUs, because the patients are bedridden for longer time and they have wasted muscles. In case of failed intubation with difficult or failed ventilation after administration of rocuronium, CICV right after induction. Other possible indications are operations that terminate prematurely, short surgeries needing profound motor block, for example, microlaryngeal surgeries. Deep relaxation is required, for example, laparoscopic surgeries, and other reversal agents are either contraindicated or ineffective, or they have shown any anaphylactic reaction. Now, dose of Sugammadex is majorly it is based on the neuromuscular monitoring of train of 4 ratio of more than 0.9. So when you have a routine block where the ratio is more than 0.9 and you're seeing train of 4 count of 2, you can use 2 milligram per kg and the reversal will occur in 2 minutes. In the moderate, when you're seeing post-tetanic count of 1 or 2, you have to use a higher dose, 4 milligram per kg. The reversal will occur in 3 minutes. Whereas you want to reverse the patient from a profound deep block right after the induction, sometimes 3 to 5 minutes after giving neuromuscular block. Again, just a visual impression of this thing. When you are seeing a train of 4 count of 3 and 4, using all the 4 twitches, you can use 2 milligram per kg. When you are seeing only one twitch of train of 4, or you are seeing low PTC, then you have to use 4 milligram per kg. And when you want an immediate response, or there is no response seen on the neuromuscular blocking agent and you want to reverse the patient, you have to use 16 milligram per kg. Now, Sugammadex is a hydrophilic. It doesn't get distributed in the fat compartment easily. So calculating the dose in obese patients according to the total body weight will be too large. So it should be calculated by ideal body weight in morbidly obese patients. Having said that, they have said that they found a post operative curization or residual curization in morbidly obese patient even when the ratio of train of 4 was 0.9, more than 0.9. So in those patients, they have recommended that train of 4 ratio should be 1. In the lean patients, that you can calculate the dose by total body weight or ideal body weight, which are more or less similar in those patients. Why we need to use rocuronium? Not to use the Sugammadex, of course. It is an alternative to succinyl choline for rapid sequence induction, and it is cardiostable. But why not use choline, which we have been using for many years? Choline has been black box warned by US FDA. Apart from routine complications like muscle pain, bradycardia, raised ICT, IOP, masseter and malignant hyperthermia, they found that in undiagnosed muscular dystrophy cases, succinyl choline has cause cardiac arrest because of the hyperkalemia, and mortality in those cases were close to 50%. And because these cases were undiagnosed, the patients were practically labeled normal before the surgery, and they landed up in cardiac arrest because of use of scoline. Another problem with succinylcholine is pseudocholinesterase deficiency. And also, one of the studies has found that there is an interaction with statins, which many patients these days are on. They cause myoglobinuria and kidney injuries. So, in a study which was done about use of scoline, one of the studies by Dr. Bajwa, he has mentioned that the incidence is rare and the severity is yet to be assessed. But use of scoline worldwide has significantly reduced. The Western world has practically moved away from scoline. And in his presentation, he has mentioned one Chinese proverb which says, spare no virtue even if minor, and do no harm even if it is trivial. So any minor trivial complication that we can avoid by avoiding a procedural drug, we should be following that. Now, in current practice, what we use is neostigmine, which is acetylcholinesterase inhibitor. The side effects are, it mandates the simultaneous use of anticholinergic agent to avoid the muscarinic effects like bradycardia and salivation. It is only efficacious if the recovery from the neuromuscular block has begun. So if you're seeing train of 4 count of 2, then only you should be giving neostigmine. You cannot reverse the deep block. Indirect mechanism of action, and so the unpredictable efficacy. It also takes about 8 minutes to have a maximum effect. Neostigmine has ceiling effect, so increasing the dose or repeated doses may not help. Rather, excessive dosing can cause depolarizing block, prolonged muscarinic effects in patients with renal insufficiency, because it entirely depends on the renal excretion. Neostigmine has a very low allergic potential. There was a study of impact of anesthetic drugs and adjuvants on ECG markers of torsidogenicity, where they have mentioned that the succinylcholine produces QTc prolongation, which can be attenuated by opioids and beta blockers. Non-depolarizing neuromuscular drugs do not have this QTc prolongation, and reversal of neuromuscular block with neostigmine and anticholinergic combination has been associated with significant QTc prolongation leading to torsade, which, while this effect has not been observed with Sugammadex even at the higher doses. There is a Cochrane review about efficacy and safety of Sugammadex versus neostigmine in reversing neuromuscular block in adults, where they have included 41 randomized controlled trials, and the number of patients studied were over 4,000. And they have said that they have evaluated the moderate to deep block and any side effects of using both the drugs, and the results states that the Sugammadex is more efficient and safer than neostigmine as a reversal agent. What are the contraindications or adverse effects of Sugammadex? Hypersensitivity. There are routine minor hypersensitivity reactions like urticaria, pruritus, nausea, mostly observed at the high doses. They were treatable, but also there have been anaphylaxis reported causing hypotension, bradycardia and death with Sugammadex, though the incidence has been rare. Renal impairment is relative contraindication when the creatinine clearance is less than 30 ml per minute. The allergic reactions were noted within 5 minutes of administration. Drug interactions of Sugammadex, it is physically incompatible with ondansetron, verapamil and ranitidine. There is a displacement reaction when the complex formed by Sugammadex rocuronium has been displaced. It has been observed with diclofenac, but it is yet in clinical studies and yet to be proven. And capture reaction when Sugammadex instead of rocuronium molecule captures any other molecule. For example, it captures the hormonal contraceptive. So if you are giving Sugammadex to a patient who is on progesterone, hormonal contraceptive, it should be considered as a missed dose of contraceptive, and patient should be advised to use other methods of contraception. And Sugammadex has not been very well studied in pregnant patient, lactating mothers and pediatric age groups. So clinical data is insufficient in these groups. Economic assessment of Sugammadex, there are few studies which calculated the cost effectiveness of Sugammadex. I have taken reference from these two studies majorly, and to summarize this cost effectiveness analysis was a little complicated for me to understand as well, but what I could understand from that the Sugammadex is cost effective if it is saving any of the OT time. So that includes the electricity used or staff charges or overtime that needs to be paid with lengthy surgeries or lengthy reversals. If it is cost effective, it is reducing the mortality. Now specifically in the younger age group, so what they have done is that they have evaluated in terms of quality adjusted life years. So if there is any complication with the reversal or in a young patient and you are using Sugammadex, the quality adjusted life years you are giving to this young patient are certainly cost effective as compared to the cost of the drug that you're using. And they are cost effective. Sugammadex is cost effective in CI/CV event, can't intubate, can't ventilate event, especially if the surgery has to go ahead. So if you are giving neuromuscular blocking drug and you are having a CI/CV situation and you reverse with Sugammadex and the surgery then is conducted using another method of intubation and ventilation, then it is certainly cost effective. But yes, if in those events most of the time the surgery is postponed, in that case the Sugammadex use has not been proven to be cost effective. It is cost effective, it is reducing the morbidity, specifically with the respiratory complication. It has a great advantage. It reduces the respiratory complications in the post-operative care unit and post-anesthesia time. It has not shown reduced hospital stay though. There has been recently conducted study published in 23 which does the analysis of association of Sugammadex with length of hospital stay in patients undergoing major abdominal surgeries. It's a single center cohort conducted over 4 years, and the primary outcome studied was length of hospital stay. Along with that, they also studied the post-anesthesia care unit stay, post-operative ambulation time, and time to first defecation and incidence of pulmonary complications. And they have said that the neuromuscular blockade reversal with Sugammadex after abdominal surgery demonstrated an excellent recovery profile and was associated with decreased risk of pneumonia, though the hospital stay was not affected by Sugammadex use. So my take-home message is Sugammadex is a revolutionary drug for complete reversal. Quantitative method of analysis is better than the qualitative assessment for neuromuscular recovery, though it should be associated with clinical assessment and respiratory measurements. Sugammadex has minimal adverse effects. It is costly, but it could be life-saving in certain situations. And recent good news is that 2 of the pharmaceutical companies have launched Sugammadex in India, and one of them is quite cheaper, so we can probably start using it. Getting acquainted with this new drug is very important for its use in critical situations like CI/CV, and that was the purpose of this presentation. Thank you.